right, and let's start the webinar. All right, we'll give a couple of minutes for a couple of seconds for people to get in. Welcome, everybody. All right. Welcome, everyone, to this Renegade Research Roundtable. If this is your first time with us, thank you for joining us. I'm Isabel, CEO of our organization. We are a patient and caregiver-led, decentralized, and 501c3 nonprofit. We focus on complex multi-system chronic conditions such as ME/CFS and long COVID. Within this, we have 3 areas of focus: research that's agile and patient-centered, education to increase the number of clinicians treating us, and care for patients. Our work is made possible by a wonderful team of volunteers who move the wheels of our organization. Most of us have a personal interest in advancing research and care of these conditions. To stay in touch with us and hear about upcoming events, please subscribe to our newsletter and follow us on social media. We will be posting these links for you. As a nonprofit, our work also depends on donations of all sizes. You can help fund our work by donating to our funding campaign and also by sharing our campaign with those who can donate. To raise funds, we also have some affiliate discounts by partnering with companies whose products and services we have used and like. This does not constitute advice on using those products or services. As always, discuss your health with your healthcare team if you do decide to use them. Please consider using our discount codes to help fund our nonprofit work. We will share some of them in the comments, but stay tuned on our social media for any additional discounts. We also have a telehealth and medical coaching service. Our telehealth is based in New York and Maryland, and the coaching everywhere else. For more information, please visit Renegade Research webpage, and you can read more details in there. We also have all of our previous presentations on our YouTube channel. If you would like to check out our YouTube channel, there's a wonderful number of previous roundtables, both clinical and research-based. And to introduce today's presenter, I'm going to pass it on to our wonderful volunteer who made this roundtable possible, Ellie Brochus.
Hi. Today I'm wearing 2 volunteer hats, one for Renegade Research and one for ME Action North Carolina, our co-host, due to their recommendations of EverBetterMedicine, where Dr. Zach practices. The North Carolina State Chapter of ME Action has monthly Zoom meetings for support and occasionally for advocacy. And for more information, you can go to meaction.net/North-Carolina. We'll be posting the links in the chat, and then the chat will be saved, edited, and put on our website later. So you don't have to feel like you need to click everywhere during the talk. You can concentrate on the material being presented. On to our speaker. Zachary Spiritos is a neurogastroenterologist who specializes in treating patients with complex chronic conditions, including ME/CFS and long COVID, POTS, MCAS, EDS and HSD, and gastrointestinal dysmotility. He earned both his MD and MPH from the University of North Carolina at Chapel Hill, where he developed a passion for addressing the systemic challenges faced by patients with under-recognized illnesses. He completed his residency in internal medicine at Emory and completed his fellowship in gastroenterology at Duke University, where he focused on neurogastroenterology and disorders of gut-brain interaction. Dr. Spiritos is dedicated to supporting patients who have been dismissed, misdiagnosed, or lost in the medical system. Using a whole-person approach to care, he combines the best of conventional medicine with targeted interventions aimed at regulating the nervous system, improving sleep and movement patterns, addressing nutritional imbalances, and managing stress physiology. He works primarily with patients whose symptoms span multiple systems and don't fit neatly into one diagnosis, including individuals who require time, nuance, and interdisciplinary collaboration. Welcome, Dr. Spiritos. We are grateful you are here. Please share your slides, knowledge, and experience with us.
That's so very sweet. And thank you for the amazing introduction. Thank you for having me. I'm honored to be here. Let's get going. All right. All right. Can everybody see my screen?
Yes.
Yeah.
Okay, great. So, ever since I started practicing, I ask why a lot. Um, and I loved IBS. It made no sense to me, but I loved it. Because it made no sense to me. And everybody was different. And I didn't quite understand why some of the tools that we used worked, and why they didn't work. And so I think that I have searched for years to figure out what IBS is. And ultimately, I stumbled upon mast cells, because mast cells are unfortunately behind a lot of people's kind of chronic unexplained GI symptoms. But it's far more nuanced than that, where there is interaction between like the local immune system, hormones, the nervous system, our psyche, diet, right? There's so many inputs here. And I like to deconstruct what IBS is because it allows us to offer more personalized treatments for people as opposed to being like, take Imodium or take Pepto-Bismol or low FODMAP diet, because it's not a one size fit all approach. So today I want to take you through a journey of kind of how I conceptualize IBS. And really, I hate the term IBS, but it's just like how it's it is a exercise of understanding how our GI system moves, how we feel it, why things go wrong, and then what we can potentially do about it. So this is the hidden biology of irritable bowel syndrome, so we can all kind of move forward and understand this better, so we can treat people better. All right, so before we dive in, I want to frame how to think about IBS because the way we think about it shapes everything we do after the diagnosis itself. First, I want to challenge the traditional model. IBS is often treated as a diagnosis of exclusion, something we land on when everything else looks completely normal. But what I hope to show you is that IBS is not a diagnosis of nothing, it's a disorder of altered signaling. Second, we're going to unpack the mechanism. IBS is driven by dysfunction across the neuro-immune-autonomic system, where the gut is sensing and amplifying normal signals, what we call visceral hypersensitivity. And finally, I want to shift how we think about this clinically. If this is a signaling disorder, then our job is not just to suppress symptoms, it's to target the underlying mechanisms driving them. IBS, yeah. So IBS is defined by the Rome criteria as a disorder of the gut-brain interaction, characterized by recurrent abdominal pain occurring at least one day every week, associated with changes in bowel habits such as diarrhea, constipation, or both. What makes IBS unique and often frustrating is that there is no clear structural or biochemical abnormalities that explain people's symptoms. And this is where the concept of visceral hypersensitivity comes in. In IBS, the issue is not necessarily that the gut itself is damaged, but rather that the way in which the gut is sensed and interpreted is altered. Studies using rectal balloon distension have consistently shown that patients with IBS experience pain at significantly lower pressures, around 30 millimeters of mercury, compared to roughly 44 millimeters of mercury in healthy individuals. This finding has been reproduced across multiple studies, and up to 90% of IBS patients demonstrate heightened sensitivity. Visceral hypersensitivity and pain is a cardinal feature of IBS. And what this means clinically is that normal physiologic processes like gas, movement of food and waste, or minimal distension are perceived as painful. So the gut may be functioning normally, but the nervous system is amplifying those signals. And this is why IBS is now understood less as a diagnosis of exclusion and more as a disorder of sensory processing within the gut-brain axis. So if we step back and ask what's actually driving this hypersensitivity, one of the clearest signals is that we see dysregulation of the autonomic nervous system, which is the nervous system that drives everything behind the scenes. There's a really elegant study by Eisenbrook and colleagues where they gave IBS patients a standardized liquid meal and measured both autonomic and immune responses afterwards. What they found is pretty striking, is that IBS patients had larger increases in norepinephrine, or fight or flight hormone, and blood pressure, meaning an exaggerated sympathetic response to very normal stimuli. And importantly, this is without any increase in cortisol, suggesting that this isn't a classic HPA axis stress response. It's more of a peripheral autonomic overreaction. At the same time, these folks' immune systems were behaving very differently. They had greater increases in white counts or leukocytes and granulocytes, altered immune cell trafficking, and they failed to suppress TNF or tumor necrosis factor alpha after eating, which is a pro-inflammatory cytokine, something that normal healthy controls do. And even more interesting is that norepinephrine levels, or fight or flight hormones, were directly linked to these immune changes, suggesting that adrenergic, or the fight or flight arm of our autonomic system, signaling and immune signaling are correlated somehow. Now, layering this on with another study by Pelletiers, we see the other side of the equation, which is loss of parasympathetic control, which is our rest and digest arm of our autonomic nervous system. IBS patients with low vagal tone had higher epinephrine baseline levels, and they lost normal balance between vagal tone, or rest and digest, and cortisol that we typically see in healthy individuals. What this means is that in irritable bowel syndrome, there's low vagal tone, meaning the body has lost its normal brake on our fight or flight response, while higher epinephrine reflects an overactive stress response. And at the same time, the usual coordination between vagal signaling and cortisol, which usually helps regulate and resolve stress, is disrupted. The result is a system that is easier to activate, more intense when triggered, and slower to return to baseline. So when you put this together, IBS starts to look less like a gut problem, more like a systems problem, where sympathetic overactivity, or fight or flight overactivity, and increased inflammatory signaling are present. What's also really important to understand and to kind of harp on the pro-inflammatory state of IBS is it's not just a disorder of perception of stress, it's also associated with measurable immune activation. Even in the absence of classic signs of inflammatory bowel disease, where there's ulcerations and erythema and swelling on endoscopy, we don't have this in IBS. But there's real signs of inflammation present. In a study by Denon and colleagues, patients with IBS had significantly higher levels of IL-6 and IL-8 compared to controls. These are pro-inflammatory chemical markers or interleukins. IL-6 is a key inflammatory cytokine that helps coordinate the body's response to stress and injury, and it ramps up immune activity and is closely tied to the stress hormone system. Interleukin 8, on the other hand, is more of a recruitment signal, and it brings immune cells, specifically neutrophils, into local tissues which can amplify local inflammation. Then when you look at the immune cells themselves, another study showed that patients with IBS produce more TNF alpha, which is tumor necrosis alpha, interleukin 1 beta, and interleukin 6, even at baseline. These are pro-inflammatory markers. So yes, TNF alpha and IL-1 beta are classic pro-inflammatory cytokines, and they are early alarm signals that promote further immune activation. And this is not just academic. These cytokine levels were associated with real symptoms: urgency, loose stools, frequency, and pain, especially in IBS-D. So the takeaway here is this: IBS is not stress or a functional disorder. It involves real, low-grade inflammatory state in which immune signaling molecules actively shape symptoms, gut function, and even the stress response itself. Pulling these two notions together, the sympathetic nervous system and inflammation are not just associated, they are biologically wired to regulate each other. On one side, inflammatory signals like interleukins and tumor necrosis factor act as messengers to the brain, essentially telling the body that something is going wrong. In response, the brain activates stress pathways, including the sympathetic nervous system and the HPA axis. But then the system flips. Once the sympathetic nervous system is activated, it releases norepinephrine and immune cells and immune cells are actually designed to respond to this. They have adrenergic receptors, or receptors for norepinephrine, on their surface. So now the nervous system is directly shaping immune behavior. Now, if you bring this back to IBS, this is where the Eisenbruch data becomes really important. After a meal, patients with IBS don't just have higher norepinephrine levels, they also show abnormal immune responses at the same time. Things like altered natural killer NK cell distribution and a failure to suppress pro-inflammatory cytokines like tumor necrosis factor, which is something you'd normally expect after eating. And those immune changes actually correlate with norepinephrine levels. So the key takeaway is this: in IBS, there is likely a feedback loop in which inflammation activates the sympathetic nervous system, which then feeds back to sustain or reshape that inflammation. And that loop is likely a major driver of system persistence in these folks. So now we need to dive into how stress actually gets translated into gut physiology And CRF, or corticotropin releasing factor, is the key mediator of that process. So CRF, or corticotropin releasing factor, is the body's primary stress signaling molecule. In the brain, when we are stressed, it is released from the hypothalamus and activates the HPA axis, stimulating another hormone called ACTH, released from the pituitary, and cortisol from the adrenal glands. That is the classic systemic stress response. But CRF doesn't just act centrally within the brain, it also exists peripherally. CRF and its receptors are expressed throughout the GI tract, including enteric neurons, or nerves within the GI tract, immune cells like mast cells and macrophages, and even epithelial cells, or the innermost lining of the GI tract. So the gut has its own local CRF signaling system that can respond directly to stress independent of the brain. So rather than thinking of stress as something abstract, CRF gives it a very real biological pathway. Now, the old adage was that IBS patients were just stressed. Just take a breath, meditate, listen to Barry Manilow. It's not a good example, but any relaxing music, do some yoga, tai chi, and just relax. But here's the thing. The issue is not that patients have dramatically higher baseline levels of stress and corticotropin releasing factor, which we do not see. It's that their system responds very differently to normal levels of CRF. For example, when CRF is administered to IBS in control patients, IBS patients show a much stronger physiologic response than controls. For example, they have a larger ACTH response, indicating that the HPA axis is more reactive to the same signal. So it's not just the signal, it's the sensitivity to the signal. Downstream, CRF has much more pronounced effects in the gut as well, not just in the brain. In fact, CRF increases colonic or colon contractions in both IBS patients and controls, but in IBS, that response is significantly exaggerated, especially in the first hour. So the same stress signal produces a much stronger motor response in the gut, which helps explain symptoms like urgency and diarrhea. From an autonomic perspective, CRF shifts in studies. They've looked at CRF's response in controls and folks with IBS, and CRF shifts both groups towards sympathetic activation or fight or flight activation as it should. But IBS patients show lower parasympathetic tone at baseline after stimulation, and they don't return to baseline as quickly as controls do. So not only is the response stronger to CRF, there is a more sustained response, and there's also a loss of recovery to it. Finally, at the level of the gut tissue itself, CRF increases intestinal permeability, or leaky gut, and in controls and IBS patients, but again, the magnitude is greater in IBS. And what's really compelling is that these changes correlate with symptoms like abdominal pain, stool frequency, and severity. So when you step back and look at this across systems, brain, autonomic nervous system, gut motility, local immune function, the pattern is remarkably consistent. It's not that IBS patients have more stress or have more CRF. It's that the downstream system is more sensitive to it and less able to regulate it. Okay, so let's step back and kind of just take in everything that we've talked about because it's been a lot. So if we step back and connect everything we've, yes, talked about, a clear model starts to emerge. What seems to be happening at CRF acts as a central coordinator, activating multiple systems simultaneously. When the brain perceives a stressor, CRF is released both centrally and within the gut. And it simultaneously drives two pathways. On one side, it activates the sympathetic nervous system, leading to increased norepinephrine, higher heart rate and blood pressure, and reduced vagal tone, which is our parasympathetic arm of our autonomic nervous system, or our rest and digest phase. On the other side, it directly engages the immune system. CRF can increase cytokine production and inflammatory signaling. And these two systems don't operate independently. They seem to reinforce each other. Sympathetic signaling can further amplify immune activation, while inflammatory mediators can feed back and increase sympathetic tone. And what you end up is not a one-way pathway, but a self-amplifying loop between the nervous system and the immune system. And it's not that these patients are experiencing more stress, as we discussed. It's that their system responds differently to the same signals. The CRF signal produces a stronger and more prolonged activation of both the sympathetic and immune pathways, and the system has a harder time returning to baseline. Even So everyday stimuli like eating can trigger this loop. So the real question is, why has this system become so sensitive and self-reinforcing? Okay, so the next step. And now we have to look at the intestinal tissue itself. And that's where the gut, the immune system, the gut lining or barrier, and the nervous system all start to intersect. And let's look at the gut tissue. Um, so as I just asked, why does the same stress signal like CRF produce a much more inflammatory and symptomatic response in patients with irritable bowel syndrome? And this is where mast cells come into the picture. Mast cells express CRF receptors. They can directly respond to stress signals, and they sit right next to enteric nerves or the nerves within the gut. That positioning allows them to translate neural stress signals into immune activation and barrier changes or more leakiness within the gut. And what the data suggests is that the difference in IBS is not necessarily more CRF, but again, a more reactive downstream response. In other words, when CRF is released, mast cells in IBS patients are more likely to activate, releasing mediators that drive inflammation, increase leakiness or permeability, and sensitize nearby nerves. And this process is nerve dependent, meaning that CRF doesn't act directly on mast cells all the time or in isolation. It activates enteric nerves, which then signal to mast cells to degranulate. And when neural signaling is blocked, that downstream activation largely disappears, showing that the nerve mast cell connection is essential for this response. So the key question is this. In IBS, the question is not why is there more stress, but why does a normal amount of stress lead to such a heightened inflammatory response? And a large part of that answer may lie in mast cells. So now, if we take that framework, the idea that stress is translated into gut biology through the nerve mast cell interface, we can actually test this in humans, and that's exactly what a study did. They took folks with irritable bowel syndrome, specifically IBS-D, and healthy controls and placed a perfusion catheter into the segment of the jejunum, or the middle part of the small bowel, which allowed them to directly measure what the gut was doing in real time. Things like mast cell activation through tryptase, intestinal permeability through albumin leak, and fluid secretion through water flux. So what they did was they gave a placebo first and then administered CRF, or corticotropin releasing factor, essentially mimicking an acute stress signal, and tracked both systemic and gut level responses in controls and those with IBS. At the systemic level, both groups behaved the same. After CRF injection, ACTH went up, cortisol went up, heart rate went up, and people felt stress that is normal. So the brain and hormonal response was intact and comparable in both groups. But at the level of the gut, the neuroimmune interface we just talked about, that's where things diverged. IBS-D patients already had higher levels of mast cell activity and more mast cells sitting within the mucosa. And when CRF was introduced, mast cell activation increased in both groups, but increased significantly more in those with IBS-D. That was accompanied by a greater breakdown in the intestinal barrier, which was measured by albumin leak, which is a protein, and a shift towards secretion with increased water flux. And importantly, abdominal pain worsened only in those with irritable bowel syndrome, and it correlated directly with these mast cell and barrier changes. So what this shows in a very real and measurable way is that the difference in IBS is not the stress signal itself, it's again how the gut responds to it. And it really points back to that interface that we discussed. The mast cell nerve barrier system appears to be primed, so when a normal CRF signal arises, it produces an exaggerated pathological response. Okay, so now let's dive into the data on mast cells within the gut, especially in those who are symptomatic or have presumed irritable bowel syndrome. So let's move from physiology and stress signaling into looking at the actual tissue of those with IBS. And this is where the argument for mast cells as a role in those with IBS really starts to become more concrete. In one study by Barber and colleagues, excuse me, they took colonic biopsies from IBS patients and healthy controls and used tryptase staining to specifically identify mast cells, then quantified them using computerized morphometry. What they found was that the amount of mucosal area occupied by mast cells was about 181% higher in IBS patients compared to controls, so nearly double. And this wasn't just driven by a small subset. About 77% of IBS patients had mast cell levels above the normal control range. And importantly, this increase was seen in overall IBS, not just in one specific subtype. So before we even talk about what these cells are doing, The tissue itself in those with IBS is different. There's simply just more mast cells sitting in the gut mucosa in IBS than there should be, which sets the stage for a system that is inherently more reactive. Now let's take the next step, because it's not just that there are more mast cells, it's what those mast cells are actually doing. In that same study by Barber and colleagues, they went deeper and looked at mast cells under electron microscopy, and which lets you see what these cells are actually doing and whether they're actively releasing their contents. And what they found was a 150% increase in degranulating mast cells in IBS compared to controls, meaning a much higher proportion of these cells were actively engaged, releasing inflammatory mediators. They then backed this up with more functional data, and they took biopsy samples, incubated them ex vivo, and directly measured what those tissues were releasing. And again, the differences were substantial. Tryptase release, which is a key marker of mast cell activation, was about 3.7 times higher in IBS, and histamine release was roughly doubled. So when you put this together, it's not just a number story anymore. The mast cells in IBS are not only increased, they're more active, and they're releasing more mediators that can directly influence nerves, the barrier, and gut functions. And that really strengthens the argument that these cells are not just bystanders, they are likely key drivers of downstream pathophysiology that we see in irritable bowel syndrome. Okay, so let's take another step forward here, because it's one thing to show that mast cells are increased and more active, but the real question is whether those signals actually have functional consequences in patients. So in another study by Buhner and colleagues, they took supernatants from colonic biopsies. So essentially, the soluble factors released from IBS tissues. So they take biopsies, they submerge it in water, and let the chemicals and neuropeptides within those cells release into the water, and then release into the liquid, and then they take that liquid. And they applied that directly to human submucosal enteric neurons outside the body, measuring neuronal release in real time, or neuronal firing in real time. And what they found was that supernatants from IBS patients activated about 58% of neurons, whereas supernatants from healthy controls had little to no effect. So the tissue itself is releasing signals that are capable of directly exciting the enteric nervous system. And when you look more closely, this neuronal activation correlated with mast cell-related mediators, including tryptase, histamine, and serotonin. And importantly, when they pharmacologically blocked proteases, histamine, and serotonin, the neuronal activity they saw was significantly reduced. So this really closes the loop. IBS tissue is not just different in composition, it is actively releasing biologically meaningful signals that can directly stimulate nerves. And many of those signals trace back to mast cell activity. All right, let's take one more step forward. And it's not just these mast cells are increased, and it's not just that they're more active, it's also where they're located. In that same work by Barber and colleagues, that first study I alluded to, they used electron microscopy to look at the spatial relationship between mast cells and nerve fibers in the gut. And what they found was a roughly 223% increase in mast cells located within 5 microns, or a very small distance, within nerve fibers in IBS compared to controls. In many cases, these cells weren't just nearby, they were in direct proximity and sometimes even showed membrane-to-membrane contact with nerve endings. And this positioning actually mattered clinically. The closer mast cells were to nerves, the more severe and more frequent the patient's abdominal pain was, showing strong correlations with both pain severity and frequency. So when you put all of this together, it's not just a story of more mast cells or even more active mast cells, it's they're strategically positioned right next to nerves that they can influence. And that proximity allows their mediators like histamine and proteases to directly affect neuronal signaling, making them far more capable of driving the symptoms that we see in irritable bowel syndrome. So before I move forward, I want to come back to an earlier point, how corticotropin releasing factor, or CRF, links the autonomic nervous system and the immune system, and how these two systems seem to reinforce each other. And I'm starting to, this is the belief I held for a while, but I'm starting to rethink that claim because I'm actually wondering whether this is a more of a linear model where inflammation from mast cells actually just drives the sympathetic tone. Mast cells are uniquely positioned to influence the sympathetic nervous system, and we see it all the time clinically. And from a mechanistic perspective, mast cells can influence the sympathetic nervous system both anatomically and functionally. They are located in close proximity to autonomic nerves, blood vessels, and key regulatory sites, including the carotid body, heart, adrenal glands, and central autonomic regions of the brain. This enables them to directly modulate autonomic signaling. And importantly, mast cells are not just passive responders. They store and release catecholamines like norepinephrine and epinephrine, or fight or flight hormones, enabling them to locally amplify adrenergic tone, or a fight or flight tone. In addition, when activated, mast cells release a range of mediators, as we spoke about, including histamine, pro-inflammatory cytokines like interleukin-6, and neuropeptides like corticotropin-releasing hormone that directly engage the body's stress pathways. And beyond peripheral effects, mast cells also contribute to central mechanisms that sustain sympathetic activity. They can activate microglia, which are these kind of very helpful cells from the brain, and increase the blood-brain barrier permeability, promoting neuroinflammation and sensitization within central autonomic networks, tipping the scale towards more sympathetic activation. Taken together, these findings suggest that mast cells may act as neuroimmune amplifiers that drive and sustain sympathetic dominance through direct catecholamine signaling, activation of stress pathways, and reinforcement of central autonomic dysregulation. So now that mast cells are caught at the scene of the crime, let's talk about how they cause visceral hypersensitivity and how they cause symptoms. So, what this really comes down to is how mast cells translate inflammation into pain. And one of the key ways they do this is through a channel called TRPV1. TRPV1 sits on sensory nerves that innervate the gut, and you can think of them as pain amplifiers. Under normal conditions, it responds to things like heat, acid, or chemical stimuli like capsaicin, but in the presence of inflammation, it becomes so much more sensitive. So let's drive into TRPV1 for a moment. Yes, so there's a really elegant study showing how activation of the TRPV1 channel can lead to chronic pain. In a murine or mouse colitis model, or inflammation of the colon, in which they induced acute inflammation in mouse colons, even after the inflammation had completely resolved, the animal still had persistent visceral hypersensitivity or pain. During that time, it was found that the TRPV expression remained very elevated. And the most important finding, though, is when they removed TRPV from these mice, these knockout mice still experience inflammation and acute pain during the colitis, but when it resolved, the hypersensitivity resolved as well. So the key takeaway was this: the inflammation may start the process, but TRPV is what allows the pain signal to persist. It's one of the key molecular volume knobs that turns a normal sensation into chronic visceral pain. All right, so now let's talk about the relation between mast cells and TRPV1. We already know that in human studies that mast cells are increased, more active, positioned right next to the nerve fibers, and releasing mediators like histamine and tryptase that can directly activate neurons. But beyond activation, these mediators directly sensitize TRPV1, lowering its threshold so that normal gut activities like stretch, digestion, simply moving waste can now trigger pain. Under normal conditions, TRPV1 activates around 42 degrees Celsius, but when inflammatory mediators like prostaglandins, bradykinin, and other mast cell derived signals are introduced, intracellular pathways are activated, lowering the channel's activation threshold. In experimental systems, these neurochemicals can shift the pain threshold down into the physiologic range, sometimes close to body temperature, meaning that the channel can now be triggered by normal, non-painful stimuli. As a result, TRPV1 becomes hyperresponsive, firing more easily and more intensely, which clinically shows up as allodynia or hyperalgesia, effectively with light touch or just eating a cheeseburger can be incredibly painful. And importantly, this process becomes self-sustaining. When TRPV1 fires, it releases neuropeptides like substance P and CGRP, which then activate nearby mast cells, leading to even more mediator release and further sensitization. So instead of a one-time signal, you now have this feedback loop with mast cells and TRPV1 continuously amplifying each other. And that's really the key point. Inflammation may start the process, but mast cell-driven TRPV1 sensitization keeps the pain signal going. So to demonstrate the functional significance of the mast cell and TRPV1 relationship, in this one study, they obtained rectal biopsy specimens from IBS and healthy controls and directly measured how submucosal neurons, or neurons just beneath the superficial layer of the rectum, responded to capsaicin, which is a chemical that really aggravates TRPV1 nerve channels. They found that neurons from IBS patients had significantly larger calcium responses and a greater number of activated neurons than controls, despite no increase in TRPV1 expression. And that's a key point. It isn't that there's more TRPV1, it's that it's just more sensitive TRPV1. And they showed that the sensitization could be reproduced by exposing neurons to biopsy supernatants or to histamine directly. And histamine is one of the most potent mediators that mast cells secrete. And importantly, when they blocked H1 or histamine receptors, that effect on the TRPV1 was significantly reduced or completely abolished. Mechanistically, histamine acting through these H1 receptors activates intracellular pathways, such as phospholipase C and protein kinase C, which phosphorylate or change TRPV1, lowering its activation threshold. And clinically, that matters because when they gave an H1 blocker, specifically Avastin, patients in this study had significant reductions in abdominal pain and improved symptom relief without changing inflammation at all. So the key takeaway is this: histamine is not just a marker of mast cell activity, it's one of the key mediators that amplifies pain via sensitization of TRPV1 channels on nerves. So at this point, I've tried to build a compelling case that mast cells are central players in IBS, but that naturally raises the next question. Why are they overactive to begin with? Broadly, there's two ways to think about this. The first is intrinsic dysfunction, where the mast cell itself is dysfunctional or abnormal. And the classic example of this is systemic mastocytosis, where mast cells are clonally dysregulated and prone to inappropriate activation, regardless of the environment. But that's the minority of cases. That's an oncologic process. The much more common, in my opinion, model, and the one that likely applies to IBS and other complex mast cell chronic issues, is extrinsic or environmental overactivation. In this model, the mast cell itself is structurally normal, but it lives in a tissue environment that is constantly provoking it. And what's really important from a biologic standpoint is that mast cells are designed to be sensors of their environment. They express pattern recognition receptors that respond to danger signals and are tightly integrated with both the nervous system and the epithelial or the lining of the intestines. So when that environment is altered, whether it's barrier disruption, microbial signals from bacteria, viruses, or parasites, or ongoing neural input, the mast cells interpret that as a threat and continue to activate. And that shifts the question from what's wrong with the mast cell to what is the mast cell responding to? So when you take a step back and look more broadly, in most patients, the bigger story is not, again, intrinsic mast cell disease, it's the environment in which those mast cells are living in. And one of the central ideas that has emerged from the recent literature is the epithelial barrier hypothesis. The gut lining is supposed to act as a controlled interface between the outside world and the immune system. But when that barrier is disrupted, you start to allow more antigens, microbial products, toxins, and irritants to cross into that tissue, and that fundamentally changes what the immune system is exposed to. At the same time, mast cells are uniquely positioned at that interface, sitting right next to nerves and epithelial surfaces, constantly sampling the environment. And they don't just respond to pathogens, they respond to danger signals, which we call DAMPs, and to signals coming from nerves like neuropeptides. So when the barrier is disrupted, you're not just increasing exposure, you're increasing signal. And if we layer that on to modern environmental factors, pollutants, chemicals, processed foods, microbiome disruption, antibiotics, then repeated physiologic stressors like infection, inflammation, or even hormonal changes, and you start to create a system that is constantly being provoked. So in my opinion, the key takeaway here is not that mast cells are misfiring because they are inherently abnormal. They may be doing exactly what they're designed to do, but it's in an environment that is chronically signaling danger. So to bring this back to the real world, one of the key upstream drivers that we have is environmental exposure, specifically how modern exposures can disrupt barrier function and push this system into a chronically activated state. We know that daily exposure to things like detergents, fragrances, pollutants, and cleaning agents is nearly unavoidable. And importantly, even at very low concentrations, these substances can directly impair epithelial barrier integrity. In experimental models, common surfactants decrease tight junction integrity, release trans epithelial resistance, and increase permeability, essentially making our barriers more leaky. Similar findings have shown in airway epithelium, where even highly diluted exposures disrupt tight junctions and trigger inflammatory signaling, including IL-33, which is a highly inflammatory interleukin, one of the body's key danger signals. Now, biologically, once that barrier is disrupted, you change what the immune system and nervous system are exposed to. More antigens, toxins, and microbial products cross into the tissue. And that triggers danger signals from epithelial cells and neuropeptides from sensory nerves. Exactly the signals mast cells are designed to respond to. And over time, with repeated exposures or hits, whether that's infection, inflammation, or environmental stressors, the system can shift into this persistent danger sensing state. And this is where the concept of toxicant-induced loss of tolerance, or TILT, really becomes helpful. The idea is that after a certain threshold or exposure, the system loses its ability to tolerate what were previously harmless stimuli. So now things like foods, smells, temperature changes, or chemicals, things that should be neutral, start triggering symptoms. And clinically, that's what we see in mast cell activation syndrome. Patients with MCAS become progressively more sensitive to environmental toxins and triggers, often before they even have a diagnosis. For example, if you ask someone with MCAS to walk into like a Yankee Candle or Bed Bath & Beyond and expose themselves to all the synthetic fragrances, they'd often rather run through traffic. So the key takeaway is this. In many patients, mast cells are not intrinsically abnormal. They're responding to an environment that is shifted into a constant state and signal of threat. And once that threshold is crossed, the system doesn't just react, it stays overreactive. And once we understand that mechanism, the treatment strategy becomes a lot more intuitive, or at least our initial treatment strategy. If the mast cells are driving symptoms, then one of the most logical first steps is to target the downstream signaling, specifically histamine. So just to pivot, we're going to be talking about now how we treat some of these symptoms in IBS through the lens of mast cell activation syndrome. So yes, one of our initial treatment targets is histamine. And histamine acts through H1 and H2 receptors that are distributed throughout the entire body, including the gut, the nervous system, and the vasculature. H1 receptors are particularly important for pain. They sit on sensory nerves and contribute to visceral hypersensitivity, as well as smooth muscles and lead to smooth muscle contraction, and also central symptoms like anxiety and nausea. H2 blockers, on the other hand, are on different sets of end organs and play a complementary role, especially in acid secretion, vascular effects, and even cardiac symptoms like palpitations. And we actually have clinical data to support blocking histamine improving symptoms. In a randomized control trial using the H1 blocker Avastin in IBS patients, there was a statistically significant improvement in global symptom relief compared to placebo, along with reductions in abdominal pain. And in a separate randomized trial looking at ciproheptadine, another H1 blocker, in functional abdominal pain, about 85% of patients had meaningful improvement compared to about 35% in placebo group, which was statistically significant. So the takeaway here is pretty straightforward, is that histamine is not just present, it is functionally relevant in a lot of these patients. And by blocking histamine signaling, particularly at the H1 and H2 receptors, you can directly reduce visceral hypersensitivity and improve symptoms. Unfortunately, histamine is only one of the major outputs of mast cells, and that's where leukotrienes come into the picture as well. Mast cells also produce leukotrienes during activation, and these are lipid mediators that tend to have a more sustained and inflammatory effect compared to histamine. They act primarily through the cysteinoleukotriene receptor, which is expressed on smooth muscle, like in the gut and the lungs, immune cells, and vascular tissue. Functionally, leukotrienes affect many of the same systems we've been talking about. In the gut, they increase smooth muscle contraction, which can drive cramping and urgency. They increase vascular permeability, which contributes to swelling and diarrhea. And they amplify inflammatory signaling pathways, including cytokines like TNF alpha and interleukin 1 beta, which can further feed into neuroinflammation and visceral hypersensitivity. And again, this isn't just theoretical, we have preclinical data to support it. In an experimental IBS model blocking cysteinoleukotriene receptor with montelukast or Singulair, this led to a reduced visceral hypersensitivity in a lot of these patients. It also reduced stool frequency and dampened inflammatory signaling, including decreases in an inflammatory pathway called NF-kappa beta and pro-inflammatory cytokines, along with an increase in anti-inflammatory signaling like interleukin 10, which is an anti-inflammatory interleukin. So mast cells are not just a histamine story. They are a multi-mediator system, and leukotrienes represent another important pathway that can sustain inflammation. Okay. So If mast cells are truly driving symptoms in IBS, then we should not only focus on blocking mediators like histamine and leukotrienes, but also quieting the mast cells themselves. Ketotifen is interesting. It is a mast cell stabilizer because it works in two ways. It blocks H1 receptors or antihistamine receptors and also stabilizes mast cells themselves, preventing them from degranulating in the first place. So instead of just blocking one mediator like histamine, you're reducing the release of multiple mediators simultaneously. Histamine, tryptase, cytokines, all the signals that we've been talking about. And we actually, again, fortunately have randomized controlled trial data in this as well to support this. In one study of IBS-D patients, or irritable bowel syndrome with diarrhea folks, treated for about 8 weeks, about 76% of patients in the ketotifen group had significant improvement in GI symptoms compared to about 38% in the placebo group. But what's more important is that, or equally as important, is that there wasn't just symptom relief, there was objective improvement in visceral sensitivity, and patients could tolerate more distension on rectal balloon before experiencing pain or urgency. And going even further, when they looked at the tissue, they found that mast cell numbers decreased in the ileum, which is the most further down or distal part of the small bowel, and mast cell activation, meaning degranulation or release of mediators, was reduced across multiple regions of the gut. So this reinforces the central idea that if you change mast cell behavior, you theoretically can change the disease. Okay, moving on to a different therapy, which is cromolyn. This is another mast cell stabilizer, and it represents a different strategy. It works upstream by preventing mast cells from releasing those mediators in the first place, similar to ketotifen. Mechanistically, cromolyn stabilizes the mast cells by inhibiting a calcium-dependent degranulation, one of the key steps in the mast cell release of their contents. So instead of blocking histamine or leukotrienes after they're released, you're shutting down the entire cascade at its source, preventing the release of histamine, proteases like tryptase, cytokines, and lipid mediators all at once. And again, we have both controlled and real-world data to support this. In a randomized controlled trial of patients with IBS and food intolerances, patients were allowed to continue eating their trigger foods, and cromolyn still led to significant symptom improvement compared to placebo. And then in a more recent real-world cohort, looking at patients with IBS, functional dyspepsia, which is more upper GI pain, and gastroparesis, about 63% of patients had meaningful symptom improvement with cromolyn. The final point here is that mast cell activation is not a one-size-fits-all process, and the same is true for treatment. Which leads into the next slide, which is there's a lot of potential therapies for mast cell activation. And what we see clinically is a lot of considerable heterogeneity. Some patients are more histamine driven, some are more leukotriene driven, and some have more neuroimmune component, and others have more of a systemic and immune mediated process or picture. Because of that, treatment really needs to be individualized. And there are supportive approaches like polyphenols, vitamin C, L-theanine that can help stabilize mast cells and reduce oxidative stress. There are immune modulating therapies like Xolair, omalizumab, Plaquenil, tacrolimus, or JAK inhibitors like Xeljanz for more immune-driven cases that feel very rheumatic. And there are neuromodulatory agents like low-dose naltrexone or even benzodiazepines like Ativan in select situations which can help regulate the neuroimmune signaling that we've been talking about. So the key takeaway is that there's no single mast cell treatment. Instead, therapy are layered and tailored based on the patient's symptoms, their triggers, and what part of this network seems to be the most dysregulated in them. But I will say that in my clinical experience, and this is purely conjecture, these therapies leave a lot to be desired. They're not perfect. In fact, when I started to learn about mast cell activation syndrome and I learned about cromolyn, learned about ketotifen, I was like, finally, there's a mast cell stabilizing therapy that I can use. And I was underwhelmed by how they worked and their efficacy. And I still remain underwhelmed to this day. They have a role for sure. But if this was truly just a mast cell issue, then mast cell stabilizing therapy should work. But why don't they work all the time? And it goes back to it's not necessarily that the mast cells are dysregulated, it's the environment that may be dysregulated. And there's a new therapy that we have been using in this mast cell world that has been quite remarkable in terms of its efficacy and also its tolerance. And those are the GLP-1 agonists, more commonly known as semaglutide or tirzepatide, and their brand names being Ozempic and Zepbound. So this is a final and very important piece of the puzzle, is the emerging role of GIP and GLP agonists in treating mast cell activation syndrome. And while this is purely anecdotal, I find them to be extremely well tolerated at low microdoses, and in most cases, more effective than all the mast cell stabilizers I named to date. Maybe with the exception of Xolair sometimes and some of the immune modulators like Plaquenil. But in compared to the ketotifen, cromolans, antihistamines, like this just works better. And as far as we know, there is no GLP receptor on mast cells. So why do they work? One possible explanation is they don't work on the mast cell directly, but they actually work upstream by improving intestinal barrier functioning and tightening tight junctions, thereby reducing the signals that drive mast cell activation in the begin with. And that's how I think how and why they work so well. So traditionally, we obviously think of GLP as a metabolic hormone involved in glucose regulation and appetite, but newer data suggests that the enteroendocrine cells, L cells of our distal in bowel, so these cells that in our bowel that produce GLP or hormones, are doing something much more sophisticated. These cells that release GLP and GOP are just not sensing nutrients, they're also sensing barrier disruption and inflammation. In both animal models and humans, when the gut is exposed to inflammatory signals, something called lipopolysaccharide, GLP-1 levels rise very rapidly. And this happens when the gut barrier is disrupted, like in kind of murine models or mice models of colitis or ischemia, where luminal signals that are normally contained within the bowel because of the injury cross into the L cells, and the L cells release GLP very early, sometimes even before traditional markers of injury release. But what really moves this forward is what the GLP does next. It doesn't just correlate with injury, it appears to actively repair pathways. In preclinical models, GLP-1 receptor signaling increases the expression of key epithelial repair genes. It also strengthens the barrier itself by increasing mucin production, improving cell-to-cell adhesion, and reducing intestinal permeability after injury. At the same time, GLP helps preserve the structure of the gut. It reduces epithelial cell loss, prevents crypt cell death, and promotes regeneration of the lining. And importantly, it reshapes the immune environment, suppressing pro-inflammatory pathways like NF-kappa beta, reducing cytokines like TNF alpha and interleukin 6, and shifting immune cells towards a more repair-focused phenotype. So when you step back, this starts to look less like a purely metabolic hormone and more like part of a coordinated barrier repair response. And when the gut lining is stressed or breached, GLP-1 may serve as an early signal not only that detects injury, but helps initiate the process of restoring integrity and reestablishing balance. And I'm starting to really much believe, after my purely own clinical experience, that a small dose of a GLP can be beneficial for many folks dealing with mast cell related issues. Of course, taken on a case by case basis, dealing with symptoms related to, yes, mast cell activity. But and here's my yeah, the bottom line on GLP-1s in these folks. But kind of more globally, kind of where I'm starting to take my clinical interest is supporting the gut barrier, because I see that doing this does help a lot of folks who struggle with IBS or mast cell activation syndrome, or both. A lot of IBS is mast cell driven, but even those with mast cell activation who don't have prominent GI symptoms, that I continue to think more and more about barrier support about these patients, and I will use kind of these on a case by case basis. I haven't quite figured this out yet in terms of who benefits from what and at what doses, but I'm getting there. And one example is prebiotic fibers such as inulin. These are undigested, and they instead are fermented by gut bacteria into short chain fatty acids such as butyrate, which serve as fuel for epithelial cells and improve tight junction integrity and help shift the immune system towards a more regulated anti-inflammatory state. Similarly, something called human milk oligosaccharides or HMOs have been shown to reshape the microbiome, increase bifidobacteria, which is a very helpful bacteria within our gut, and increase short chain fatty acid or SCFA production. And then on the amino acid side, nutrients like glutamine or glutamate play a more direct role in epithelial repair. In inflammatory models, glutamate has been shown to improve villus structure, improve tight junctions, and at the same time suppress inflammatory pathways like TLR4 and NF-kappa beta. So when you step back, these are very, very different fiber, microbiome targeted compounds, and amino acid, but they all point in the same direction. They help restore barrier integrity and reduce upstream inflammatory signaling. And that's really the key here. Instead of just chasing down symptoms, we can support the system at the level where I think a lot of the process begins, the gut barrier itself. So, if we step back and put all of this together, the way that I think about IBS is not a disorder of nothing or a diagnosis of exclusion, but a disorder of amplified signaling across a neuroimmune barrier network. The symptoms are real, actually measurable, and reproducible, and they don't just show up, and unfortunately don't show up on a standard endoscopy. At the center of this, we see three key players: the nervous system, the immune system, particularly mast cells, and the gut barrier. Stress doesn't just stay in the brain, it is translated through corticotropin releasing factor, or CRF, into autonomic and immune signaling. And mast cells sit right at that interface, and in IBS, they appear to be more numerous, more active, and more closely connected to nerves. That creates a system where normal stimuli like food, distension, or subtle environmental triggers can be perceived as pain. Importantly, this is not merely or simply more stress, it's an exaggerated response to stress. And the question becomes, what has made this system more sensitive? And what I think and what we see is barrier dysfunction, environmental exposures, and prior inflammation all likely playing a role in priming that system. And this leads us to treatment. There is no single answer, but we can intervene at multiple levels: reducing stress through therapy, DBGI therapies, hypnosis, cognitive behavioral therapy, calming mast cells, blocking the mediators, regulating neuroimmune signaling, and importantly, supporting the gut barrier itself. So the takeaway is this: IBS is not a mystery. It's a systems problem. And once you understand the system, we have a lot more ways to help people. Thank you. Now I'm going to stop sharing my screen.
All right, we have some questions in there. John, do you want to take some questions?
Sure. And thanks very much, Zach, for your the talk and leading it through and the landing on the systems approach. And then what's at the core of the system? Is it the mast cells? Is it the inflammatory markers in the gut? Is it something else? Is it the toll-like receptors and so on? And is it the drivers of them or the response to them? And let's get to our questions, and I think we can have a really interesting conversation here. So first one, Rivka, do you want to come up? I don't know how to bring somebody up for a question.
I can do it.
Or I can read the questions, whichever is, and go from there.
You can start reading it, and I'll
Yeah.
ask her if she wants to come up.
Would a vagus nerve stimulation help with GI problems you're describing? I'm finding it is lessening the burning in my gut that started with COVID in 2020. Would VNS help leaky gut also?
That's a really good question. So, sorry, give me 1 second. I'll be right back. I have a 4-year-old who just walked in the room. Okay.
Nice.
4-year-olds are adorable.
So it's really fascinating. If you look through these different roundtables that we have had, I was just going to say we've got one here focusing on gut as the driver. We had one with Dr. Gold focusing on oxygenation and upper respiratory pathways as the driver. We've had vascular ones with Dr. Smith and others on getting the vascular flow and the venous flow working is the answer. And it seems that all of them zero in on the innate immune system and the toll-like 4 receptors and so on. And so in these feedback loops, they may all coexist and have different drivers. So, but can we bring Rivka up? Or just go ahead and answer. So using vagus nerve stimulation as a way to help with leaky gut.
Sorry, I
Yeah.
couldn't figure out how to unmute, but thank you in advance for answering the question. This is Rivka. Thanks.
Hey, Rivka. It's a great question. So, there is obviously the nervous system communicates with the immune system. And the way the vagus nerve stimulators work is that they ping the afferent the afferent limb of the vagus nerve, which is 80 to 90% of the vagus nerve. And the thought is that, so the afferent runs from the gut to the brain. And the thought is that then that creates kind of a feedback loop down the efferent limb to then affect immunity locally. And I think that there are so many different inputs in this system, right? Barrier dysfunction, uh, um, like overactive mast cells, diet. And you can certainly envision a scenario where involving like increasing parasympathetic tone would decrease local immunity at the level of the gut. So the answer is possibly, because this group of folks is so heterogeneous that it is feasible. And I ironically in 2 hours have a conversation with like a VNS expert who's leading me through his research because I'm fascinated by it, especially kind of low-hanging fruit, low side effect profile tools like this that may really, really work. And so anytime that you can tip the autonomic balance towards the parasympathetic tone, you're in a good spot, whether that's VNS stimulation. I've seen it work really well for people, and I've seen people be like, it didn't do anything for me, right? And so it just speaks to how heterogeneous this whole group of folks is. But it's certainly worth a shot if you feel that one, the degree of stress in your life makes symptoms worse. That you run in more sympathetic kind of fight or flight stage, like if you drop a pan next to you, whether you're going to jump out of your pants, or just, hey, if you want to give it a shot, because it is truthfully like pretty low risk. So the answer is for some people, I think it would work really well. For others, not, not so much. And I'm not quite sure if we have any objective data to kind of stratify who it works on, who it doesn't. But talking with
And
someone an hour to figure that out.
And within it, there's vagus nerve stimulation is not a singular thing. You have different parts of the afferent. So you've got them on the neck. You've got another loop that comes on the ear.
Mhm.
And then on the efferent side, all of your discussion with CRF and the hormonal responses, that doing vagus nerve stimulation is going to change your endocrine axis as well. And so is going to change what's coming downstream through the endocrine pathway, through the adrenal glands, not just through the vagus nerve efferent. So it's a very elegant way to tie this balance together so that all these things contribute. So it's not somebody's hypersensitive sympathetically or not, or and so on. And so because one of the things that rears its head in this space all the time is it this or is it that? And most of the time it's both and so it's all these things together in a systems response to keep the teeter-totter balanced is homeostasis.
Yeah.
Since I
There's usually just not one treatment, right?
Yeah.
It's usually multiple pieces of the puzzle. There's also a trigeminal piece that people are working on as well. And they've seen it work for like dysfunctional uterine bleeding, right? So you're like, what's happening here? So it's a fascinating space that I'm eager to explore more.
Since I have
Uh,
the floor, can I just ask my second question, which is, it's so weird that it's wonderful to hear that GLP-1 could help GI issues, but all the reporting that we see in the news is that it can cause GI issues. So that's confusing. And I'll sign off. Thanks again. It was a really fantastic talk.
Oh, thank you. Let's talk about this because when I bring this up, there's always a pregnant pause, and I'm like, you know what? We're going to put you on Ozempic today. 95% of the people that I put on this medication have no weight to lose. 85% of my clinic, I'm just making that up, but it feels that way, has gastroparesis, right? 50% have chronic nausea. Okay. So all signs would say this is a bad idea. Okay. So if you look at the pharmacokinetics of this medication, so when we talk about like the symptoms the side effects they cause, right? So delayed motility is certainly one of them. That happens in a dose-dependent fashion. So the higher dose that you go, the more that happens. The weight loss piece usually comes from the effects that the medication has in the hindbrain as opposed to the motility, because at week 2 to 3, it doesn't get back to baseline, but it improves. Um, and so when I use this medication for inflammatory control or gut kind of barrier protection, however you want to categorize it, I use really low doses. So I use 1/10 of a starting dose or a starting dose for weight management. We're at that level we typically say no appreciable changes in gastric motility clinically or increased nausea or weight loss. There certainly are exceptions. I'd say I've had one young woman lose a lot of weight on the lowest dose, and it made no, and she like her appetite didn't change. She just lost a lot of weight. And I was wondering if it was like inflammatory weight. I don't know, but you have to obviously watch that very carefully. But the pharmacokinetics would say that like at a very, very, very low dose, it's actually quite safe, even if those who are predisposed to slow motility. And I've seen it clinically. I use it quite a bit, and there's always concerns, and I can't always promise somebody that it's going to go perfectly well, but we watch people really closely, and at a very, very low dose, like rarely do people have a lot of side effects on it. The nausea piece is interesting because anybody who prescribes this medication regularly will tell you that if a patient is nauseous on it, it's because the dose is too high, right? And so um, you don't really see it at a low dose. And conversely, if people are dealing with chronic nausea due to central mast cell activation within like the inner ear and neuroinflammation, then it can make that better. So it's all to say that it is a dart throw. It's a dart throw, and I find it to be incredibly successful in the vast majority of the people that I put it on, but it doesn't work every time. So inherent in putting somebody on this is just very close communication, starting low, going slow, and making no promises and expectation management because there sometimes are adjustment periods and the appetite does go down for a few weeks, but then it can come back up. But by and large, I find that for the right person, obviously this isn't a blanket statement, but the benefits far outweigh the side effects. And just one more statement. If you're going to cook up a mast cell, I don't know how many people in this room are familiar with mast cell activation or have mast cell activation syndrome. If you're going to go and cook up a medication for mast cell, you want something that you can microdose. We microdose this. You want something that avoids the GI tract because I worry about malabsorption all the time in MCAS. We see a lot of deficiencies in small bowel, vitamins and nutrients. Check. It's injection. 3, you want something that's clean. An injection just has a buffering solution in it. So it's pretty clean, no additives, no excipients. And 4, it's endogenous. It's a peptide that our body makes. So the mast cells are like, oh, I kind of know that guy. He's been around here before. So is it perfect? No. But and these are just kind of my musings. I haven't proved any of this, obviously, but that's when I think about it that way, I've made sense of why it's so well tolerated. And I would say more well tolerated than a lot of the conventional therapies in mast cell, including the ketotofins and cromolins. But certainly there are exceptions.
Great. Elisa's question, is it pushing answer live, Isabel, or is it
Yeah. Yeah, I can handle that on this end, if you
okay.
want to handle the question.
Oh, great. Does the pathway for IBS also apply to gut issues with dysautonomia POTS, since it's also mediated by the autonomic nervous system? So the crossover with other parts that show up in the constellation of ME/CFS. And
Yeah. So when I talk to someone with ME/CFS or hypermobility and mast cell, I try to put people into buckets. Is this inflammatory, like mast cell activation? Is this dysautonomia, which is it's more motility, or is this like a compression related issue like MALS or SMAS related to hypermobility? And so when we talk about like motility issues related to dysautonomia, I think of that as less IBS. I think of IBS as an inflammatory condition. But in kind of dysautonomia related GI issues, I think of that as pure motility, where like people just have there's symptoms related to gastroparesis. It doesn't hurt as much. Things just don't move through. Like you eat and you just get full immediately. Your gastric emptying test shows a lot of retained food at 4 hours, you know, slow motility, constipation, things like that. So I think of that as less IBS, where there's a lot of perturbation in the immune cells in within the GI tract. But it's also not that clean because we're also realizing that some of these gastroparetic patients is actually an immune process as well. But dysautonomia, pure dysautonomia is, I think, of more motility, hurting less and just being more uncomfortable and things moving slowly. But conversely, also people can move too fast with rapid gastric emptying, but it's more of a motility issue that is less painful, but more kind of the issues are related to handling of food.
great. Is Tara's the next question, Isabel, or is
Yes.
yep.
Hi, Dr. Spiritos. Tara Foti. I'm a public health researcher, and before I developed long COVID and ME, my research was largely focused on patient-clinician communication and rapport. So I just wanted to chat with you for a second because, you're mentioning leaky gut, you're giving us a presentation on IBS, and I'm going to put these in a bucket of conditions that not every clinician believes in. And a lot of us do kind of come at this with some level of medical trauma, I'll say, or at least some experiences where we felt dismissed or unheard. And so I'm wondering if you have any advice for folks with GI symptoms or who have leaky gut or IBS, and how we can approach that with our clinician that you think maybe would give us a better chance of not being ignored or dismissed.
That's a really good question. You know, I hate to be jaded, but I think you'll know a provider who's going to go to bat for you when you meet with them, right? Even if they don't know, like I've met loads of providers who are relatively unfamiliar with mast cell or hypermobility related issues or dysautonomia that are just curious and will continue to read and research. But if a provider is already coming into it like closed-minded, I'm not sure you can convince them, unfortunately. Um, you can try. I don't know the right way to do it. I think it's just finding the right person that will go to bat for you. They don't have to be the most knowledgeable in the space, but they just have to, that person can connect you with someone who is. Um, and, you know, the, providers have such a limited window in time in traditional healthcare. And when you see a GI doctor, a lot of it's like they're surgical adjacent. Like they really just want to get you in for a procedure a lot. I hate to say it, like that's kind of that's what keeps keeps the clinic churning is procedures. And so um, they don't have a lot of time in the clinic to kind of go through these things and do their own research. And because if you come with papers, they're going to be like, oh my gosh, like I'm just super overwhelmed. Conversely, if um, you know, eh, it's just, I think they are overwhelmed by the limited time they have in clinic. And some people have kind of made up their mind about certain issues. And so I think it's just identifying the right provider to go to bat for you. The issue with leaky gut is that we weren't taught about it. Like none of it was in training. Um, and it's real. Like there's real great science about leakiness, except it's been co-opted to mean something that it's not, right? People are like, I have leaky gut. I was like, well, okay, but like it has to be due to something, right? So it's like leakiness due to mast cell, or like it's not it's or it's not a people just say I have leaky gut, but like we don't really know what that means because you can't really measure it. Like there's no tests out there that measure that, and it's been turned into something that is kind of magical, fantastical, like take these supplements and make it go away. And so that's why I think there's a lot of pushback from traditional medicine to buy into. One, they haven't been taught about it, and then there's a lot of narratives that are false out there about leaky gut and how to heal it. Um, but I kind of went on a tangent there, but I think it's just, yeah, finding someone that'll go to bat for you.
Is this why you opened your clinic so that you could have time with people who haven't had time?
Yeah, yeah. You know, if you're just dealing with reflux disease or people with difficulty swallowing, and it's like, yep, sounds like you need an endoscopy, or you're having rectal bleeding, yep, sounds like you need a colonoscopy. Like, yes, you can do that in 15 to 30 minutes. Um, but these issues related to hypermobility, related to ME/CFS, related to dysautonomia are complex, nuanced, not only from a medical perspective, but just to listen to somebody and then kind of take in what they've been through. Because, um, I mean, it's more than just like prescribing a medication. I think it's like recognizing what people have, like seeing them and recognizing their struggle to at least say like I can't imagine what this has been like for you, but like holy crap, I'm here with you and I may not have perfect answers, but like we will figure this out together. And that takes time. But not only like the clinic time itself, but like messaging between visits. Like this is a far from a perfect science, right? We're all trying to figure this out. And a lot of the buttons that we press don't work, right? Like sometimes I think something's work and it doesn't, right? But if I'm spending half my time in the hospital covering an inpatient team and doing bleeding cases and scoping, like I don't have enough time to do that. So I just, to do this kind of medicine, I think requires just a lot of communication and just um and it's ultimate teamwork between patient and provider. And you can't do that when you're scoping half the time. So yeah.
Great perspective.
Thank you.
Unfortunately, very real too.
Yeah.
Um, let's see. So going back to the top, how does HAT figure into this issue? Also, post-rectal cancer, radiation, chemo, surgery. So mechanical and functional changes as an environmental input, I guess, as well.
Yeah, so HAT is tough. We think that there's a lot of people with HAT that are doing just fine and have no symptoms at all. And then there's people who have HAT and have a lot of symptoms. The question is like, do they have mast cell? And like HAT is like a subset of people with mast cell induced symptoms because there's certainly a lot of people with
Do you want
HAT.
to just share with folks the acronym also?
Sorry, yeah. So it's hereditary alpha tryptophanemia.
Yep.
So some people just make more tryptase. They have a genetic mutation that just their mast cells create more tryptase, and that is the biomarker that we use to look for systemic mastocytosis. And sometimes it's one of the markers we can look at to test people for mast cell activation syndrome. Um, and so, mast cell activation syndrome, where these mast cells are being perturbed too much and are overactive. HAT are mast cells that make a lot of tryptase. And we certainly see some folks with HAT have a lot of symptoms consistent with mast cell. We see patients with mast cell without HAT, and then we see patients who have incidentally high tryptase levels, HAT, with no symptoms. And so I tend to think of HAT as just like a subset of mast cell activation syndrome, but I don't treat them any differently. I don't think there's therapeutic decision that pertains specifically to them. So I really don't know how that if that changes necessarily like how I think about somebody. In terms of like post radiation and if you had if you had surgery to your rectum and radiation changes, like there's a lot of things that can happen. Mainly on the level of like neuromotility, right? Like I don't know how much I couldn't catch if that person still had the rectum or if it just had radiation, just radiation.
Oh, I'm not sure. It was just
Yeah,
a general question. Yeah.
yeah. I mean, so
Yeah.
like
Yeah,
you know,
the person has the ability to speak while the question is being answered. So if you want to ask directly or add more nuance to the question, feel free.
yeah. So if there's surgery done and the rectum is not intact, obviously it changes a lot in terms of being able to poop comfortably because you don't have that reservoir of the rectum to hold stool, so you have a lot more urgency. And then if you have, you know, typically radiation can lead to more kind of neovascularization and bleeding in the rectum, but you can also develop strictures. It's not super common because radiation is so good these days. It's so focused. But yeah, it can certainly lead to structural changes and bleeding as
And
well.
with radiation or with surgery, you could have disrupted blood flow as well, and just hypoxia will activate mast cells in the interstitial tissue, so you can get another loop that way.
Yeah. I don't have a ton of experience with radiation and mast cells. I have one woman who has breast cancer and she had radiation and had a really bad mast cell flare afterwards. Um, so it showed that I think her radiation oncologist was going to write it up because it's not something that is commonly thought of within the radonc world.
Here's another one. The characterization of the colonic environment with the volume of mast cells located near the nerves and the communication with TRPV1, the calcium channel blocker, et cetera. Does that exist in the stomach as well as the colon and small intestine?
Yeah. Yeah. So we typically think of IBS as involving bowel habit changes. So presumably lower in the intestines where bowel habits are affected, like the small bowel and the colon. But there's also a cousin of IBS called functional dyspepsia, where people have pain after eating. It's described by epigastric fullness after eating, sometimes pain after eating. There's kind of two subtypes of that are kind of distinguished clinically. And it was put in this functional book out of just, put people in neuromodulators, and we can talk about why neuromodulators work, like amitriptyline, mirtazapine, nortriptyline, Cymbalta, agents like that. But there is a great paper written by Jay Pasricha from Mayo recently that is really trying to give credence to the fact that the local immune system is really perturbed in these folks as well. And they not only see a lot of mast cells, but eosinophils as well. When someone has like functional dyspepsia, the first thing people like what docs put people on is PPI. And the reason why PPIs work not that you have too much acid or a peptic ulcer or anything like that, but your TRPV receptors are more sensitized to the acid in your stomach. So, and presumably that's due to inflammation within the stomach from mast cells or eosinophils, sensitizing those TRPV1s, which are very, very sensitive to low pH. And so what PPIs do is just it increases the pH of the stomach, makes it more alkaline. So those TRPV receptors aren't being aggravated as much. So that's the thought process there. So it's kind of indirect way of treating people, although I think people aren't very satisfied with being on a high dose PPI just as a treatment plan.
And just for it sort of with that question, so the TRPVs, these calcium channels, they're actually on the core of a lot of mitochondria all over the place. And so there's a whole bunch of balance of for energy and kind of keeping cells in order, where you have what's called the sodium potassium pump, and you have the energy making energy with glycolysis or the Krebs cycle or the oxygen when oxygen's there, and you get about 10 times more energy per unit of sugar when that happens. And that ATP or the energy is used to make the sodium potassium pump work, and that ends up making sort of the balance of the membrane, the voltage balance or the membrane potential. Uh, it keeps it intact. That takes energy. And if the sodium potassium pump is working, then the calcium pumping will work as well. And if the ATP is around, but if there's not enough ATP around, if you're sitting in the hypoxic environment or the sodium potassium pump isn't working, then you can't keep the membrane potential, and it happens in cells all over the place and inside the cells in the mitochondria as well. So it might just be that there are, because if you step back and say, and for example, in long COVID, you have clusters of people with with neuro and fatigue, and you have clusters of people with GI, and you have clusters of people with skeletal pain is the manifestations, that those just may be the same process that we're talking about here, but happening in different places because of some of the various control systems.
Yeah. Yeah.
I think the next one is Karen is coming up to ask a question.
Yeah, thank you so much. And I really appreciate all the great information that's being shared. I had a couple questions. One is about kind of the trade-off between doing an H2 blocker every day, like famotidine, or um, worrying about whether the decrease in stomach acid might exacerbate nutrient deficiencies. And then the second one is about allergy shots, so immunotherapy injections for environmental allergies. Do you see this as working as well in kind of this patient subpopulation as it works for the general population? And do you think it's worth it to continue even though it may exacerbate some things in the short term? So thank you.
Oh yeah, great question. So if you look at, so Pepcid really stinks for reflux disease. Not a good medication. If you take it every day, it stops working in like 14 to 21 days. So I don't think it causes sustained gastric acid suppression. Like if someone has like true reflux disease, it's the guidance is to only take it for like 7 days at a time because it'll like stop working after that. And if you need it more than that, we got to think about why that is and what else to do. So I don't think of Pepcid as causing vitamin nutrient malabsorption as opposed to like a PPI, which again, like the data is pretty soft on PPIs as well. But you still want to look out for B vitamin deficiencies there, and iron as well. But yes, I don't think Pepcid causes that. And I get that question all the time. And I think I use that answer, I phrase that answer, or I've come up with it because of like the mechanistic pharmacokinetic data on Pepcid. And also just clinically, I don't see it. I see a lot of vitamin nutrient deficiency in those with mast cell activation syndrome, but I think that's due to like this mast cell enteropathy where they just don't absorb a lot of vitamins and nutrients in the small bowel. We see iron, vitamin D, vitamin C, selenium, zinc, copper, B12, sometimes folic acid as well. So I think Pepcid's okay to take long term, to be honest with you. So I don't see any issue there, but obviously if anybody has any different experiences, I'd love to hear that. And then number two is allergy shots. Yeah, I'm definitely not an allergist. I'm not sure I can comment a lot on that. I personally have not seen any of my patients benefit from allergy shots. And because it's like, it's just sensitizing the system against kind of a reaction. I just find that when mast cells are dysregulated, they'll react to something new every day, right? It's rarely just like one thing, like ragweed or something like that. If you truthfully have IgE related allergies aside from mast cell activation syndrome, I think allergy shots are probably a wonderful idea. I have one patient who does that and she swears by them, but I also have loads of people who don't. So I think that's probably a question for an allergist, but from my perspective, for mast cell activation syndrome, I don't think it plays a big role.
Somebody wanted to expand on that question in terms of PPIs versus the H2.
Me? Oh, PPI is very H2. Yeah, so PPIs are a wonderful reflux medication. People have reflux. Reflux stinks. You will always try to figure out why someone has reflux and figure that out, whether it's like weight loss or hiatal hernia repair or, and some people need it. Some people have eosinophilic esophagitis and don't want to do dietary changes. Some people have horrible, peptic strictures and need PPIs. So PPIs are a good drug for the right person. It's like anything else, right? Like if I don't have high blood pressure, but if I took hydrochlorothiazide, I'm not going to feel good, right? So feel well. So every medication is a tool, right? And so PPIs are wonderful for the right person. Unfortunately, they are overprescribed and as such are demonized because everybody and their mother is on it, and usually it's inappropriate. There are other ways to figure out reflux. It is you go in for like gallbladder pain and you'll be discharged with a PPI, prescription for 11 months. So I have not looked at the data in a couple years, but the data for PPIs and malabsorption is not strong. It's correlation, not causation, population-based studies. That said, the mechanism is certainly there, right? So acid is required for like iron absorption and B12 absorption. Like you think of it like there's a condition called pernicious anemia or AMAG, which is autoimmune metaplastic atrophic gastropathy, where there's an autoimmune condition against the stomach. Stomach can't make acid because the parietal cells, which make acid, are damaged. And so if you just extrapolate from that, those people get iron deficiency and B12 deficiency. So if someone is on a chronic PPI, it's probably a good idea to get kind of those B vitamins and iron checked on an annual basis. But again, the data doesn't support that necessarily. It's just like, why not? Just give it a shot or check it out. In terms of like, there's a lot of other questions about causing like microbiome changes, and like I get why, but again, that has not been substantiated. It's a pretty well tolerated medication, but again, like anything else, you should only be on it if you need it.
Great. So we still have still about 15 or 20 questions here. Your talk has generated a lot, and I want to be cognizant of your time as well. But maybe we start turning this into a lightning round and see if we can bang through some of them. Is it possible to work more upstream and eventually not need all the drugs? So can you get back to a clean slate, essentially?
I'll just say this. I've had two patients move to France because they feel so much better out there. I think the best way to treat mast cell is to get off the beaten path. Like there's data for 5G from our phones messing with their microbiome, right? Like I think I have patients who can't stay near the computer because the EMF from the computer makes their mast cells angry. So I think like I am not an environmental scientist. I don't know anything about this stuff. I'm just learning and reading more about it because it's fascinating. But I think, mast cells are a protective mechanism against all these threats in our environment. Our evolution was doing this and society just did this, right? Since the industrial revolution in the 50s, right? The degree of atopic and inflammatory conditions are through the roof. Allergies, asthma, Crohn's disease, eosinophilic disorders. Like, why is that? It's because we are exposed to all this junk. So, what I tell people is that until we can do a radical change of our environment, which you and I know is not coming anytime soon, I think the best way to treat this is to make life as I give everybody this really long, exhaustive sheet to kind of go over their home environment to make it as like dye-free, scent-free, chemical-free as possible. It's impossible to do, and you can't control what your Aunt Lisa comes over wearing perfume, right? Or what if your husband loves his cologne, like you can't. I don't know. I'm not going to get in the middle of that. But I think the environment plays such a big role in symptoms and mast cell activation syndrome. And so, in all seriousness, like, I wonder, if you kind of discarded all the novelties of today's society and, lived out in the country, like would things be easier? Right. I don't know the answer to that. And you ate clean, but you see people move to different countries and they feel so much better. And like, why is that? Like, is the food chain different? Like, or just there are less VOCs around? I don't know. So
Well, and
it's all
you
about the
spoke
environment.
you spoke to these danger associated receptors and signals that
Mhm.
those when those get turned up, they will cause inflammation, cause mast cells to activate and degranulate. And when that happens, you get that feedback loop as you were describing. And those receptors themselves, the one that does LPS, the toll-like 4 receptor is COVID turns it on, mold turns it on. There's the pollutants, the 2.5 micron size pollutants that happen in air pollution from diesel. That turns it on. So you get people who have worse asthma or other problems that are near exits on a highway or something like that.
Mhm.
Lyme is a close cousin with the toll-like 2 receptor that gets the same pathways going. And they all kind of, these pathways all kind of come down to getting the NFKB and ultimately the inflammasomes, which are the sort of the inflammation bomb that is protective, but then causes trouble, lit up. And once that is happening, you're degranulating. And then when you degranulate, you push some things down the clotting pathways and make it easier to get microclots. And so there are all these loops that fly through. And so I think you're spot on with the environmental add-on there.
I'm
Yeah,
laughing here because I just made my husband throw away yet another cologne early this week.
Yeah, I spend a lot of time on it. A lot of people give me the eye roll because like, okay, well, just what medication did I take? But I really like the medication is only a band-aid, right? But I'm fascinated by the gut barrier treatments, which is not going to be everything. But I have had anecdotally a few people do really well with human milk oligosaccharide or inulin and really decrease the reactivity. It's not everything. Again, there's not one thing that solves everything. But I think I've had the most success with working upstream of mast cells as opposed to working on the mast cell. But that's just my experience. So
And then how about polyps in the GI tract? Do you see more polyps in these patients?
I do not. I do not see a lot of cancer in my patients or precancers. I don't know. I worry about the neuroinflammation. Like I'm wondering about like, and this is just I'm just making this up, but like Alzheimer's, Parkinson's, like how does that kind of shake out down the road? But in terms of cancer, I don't see a higher rate of breast cancers, colon cancers. I do not know kind of I mean, I know the pathway of like adenoma to cancer, but I don't know what's upstream of that and what causes that. Is that more metabolic? Is that more, that's a pathway that I do not know. But I just, from a purely epidemiologic perspective, I don't see it very much. I don't know if you guys do.
There's some really interesting work going on looking at Alzheimer's, folks with Alzheimer's not getting cancer in general, and folks with cancer not getting Alzheimer's in general. And so are they two sides of or two ends of the fulcrum or the pivot on the inflammatory and building side? But
Yeah, because
that's
you think
still
of
working
metabolic
itself out.
syndrome being a precursor for a lot of cancers, and mast cells play such a big role in metabolic syndrome.
Yeah.
Um, so yeah, that's where you'd think the Venn diagram would overlap, but I don't see it.
Okay, the polyps, let's see, VNS. Oh, go ahead.
Candace is up. Candace is up to
Oh,
be able
great. Okay.
to ask, and then Michael is going to ask a question, and you just asked Melissa's question on polyps, but if she has any add-on, she's also
Oh,
on
great.
after
Yeah,
Michael.
I just wanted to say that my polyps were not cancerous. They were, they were benign, but there were a lot of them. And there was also a lot of evidence of inflammation in the stomach. And the doctor said, yeah, you got a lot of inflammation in there. I don't have any idea where that's coming from.
Yeah, so gastritis is everybody with mast cell has gastritis. And
Yeah.
it's on biopsy, it's called chronic inactive gastritis is what they'll call it. Typically we think of NSAIDs doing this, H. pylori doing this, mast cell does it all the time. And people get put on a PPI, right? And it actually makes some people feel better because it's calming down those TRPV1s. But again, it's misdirected a little bit with good intention, obviously. The polyp piece is interesting because polyps, those hyperplastic polyps that just happen. I don't know why I've never really done a deep dive on them, but there's like these benign polyps. I don't know of any association with mast cell. And I have a lot of my patients obviously get colonoscopies for, symptoms, and I haven't I haven't seen any like specific correlation with any specific type of polyps. I think in my experience, it's been like with the same regularity that you'd see with anybody, like precancerous polyps, non-precancerous polyps. So I'm not sure how they're related, but it's obviously incompletely understood.
All right. Candace, do you have any? I think your question is next, if you want to unmute.
If not, you can go ahead and
All
ask.
right. Have you looked into Lael Yonker's research on the use of zonulin for leaky junctions?
Yeah, so zonulin, from what I understand, in a research perspective, works. The zonulin on like the Genova testing is not accurate. So it is still like a research tool. We don't have a sense of like what's the lower level of like agreed upon cutoff of abnormality, right? Is that age adjusted? Should that be different in someone who's young versus old? Should that be different for males and females? Um, Zonulin in those Genova testing, from what I understand, is a very non-specific marker, like like non-specific inflammation can cause it. And so I believe in it in a research setting, but not in the commercial testing. I'm not also sure I care, right? Because it won't change necessarily what we do. Um, and so it's another, I find it to be more noise without really pinning down, without really changing our treatment strategy necessarily. Because leakiness is a downstream symptom of something else, right? It's like SIBO. SIBO in itself is like, okay, well, why is it there? Right. And so it's one of those things where it's like, okay, you may have it, but it's like, it's the smoke, not the fire. And if you're treating the smoke, you're going to be on 11 medications, and which you may, in this world of ME/CFS, you may need 11 medications, but it'll just add on more unnecessary therapies and going down different rabbit holes that are probably unnecessary. That's my take.
Great. Michael, do you want to ask your question?
Yeah, yeah, I do. Thanks. Can you hear me?
Yes.
Yeah, loud and clear.
Great.
Is that
Is
you,
there
by the
any
way? Is that
who?
you underneath the Stingray?
Yeah,
Yeah.
yeah, it is. Yeah, a long time ago when I wasn't so unwell. But it is, yes, and Monterey. Question: is there any connection between mesenteric paniculitis, so-called misty mesentery that you see on CT scans, with MCAS? It's often seen as an incidental finding, but
Great question. I do not know what to make of mesenteric paniculitis. It is not something I see in MCAS with consistency. The way that I think of it as something that's idiopathic that we don't know what it is. And a lot of idiopathic things are mast cell driven, so it could be, but I don't see it as a sensitive marker for mast cell. Like all of my patients get CT scans of the belly at some point in time. I rarely see the misty mesentery. I think I have one young gentleman who has it. Is that related to mast cell or is that true and true unrelated? If you're thinking of misty mesentery, we think it's some swelling of the lymph nodes, right? Because it's some people think it's a precursor to lymphoma, and that's why you follow it with CT scans over time. So, mast cell's an inflammatory process. Stands to reason that you can have kind of more swelling on kind of the outside of the bowel because of like more congested lymph nodes. But I don't see it as being a sign or symptom of mast cell, nor is it something that I treat in and of itself. There are some people that have mesenteric paniculitis that is true and true mesenteric paniculitis, and it hurts a lot. We can't find any other reason for it people to hurt, and that has its own treatment paradigm. But with regards to like this, the question that you asked, I don't see it. I don't know if you guys have any other different experience with that. It's one of those things that I haven't really put together yet. I'm sorry. I wish I could give a more helpful answer.
no, that's great. I have another question, if that's allowed.
Sure. Quick follow-up.
Okay. Okay. So, patients who are really sensitive to medications, how do you go about getting them on and off of medications? And then I'll tag another one onto the end, which is, do you find that patients who get more neuropsychiatric symptoms as part of their MCAS sort of portfolio, are they more responsive to certain medications than others?
Can I ask you what you mean by neuroinflammation? Do you mean like neuropsychiatric or brain fog?
Neuropsych, sorry, yeah, neuropsych symptoms. So, you see some people get panic attacks and they'll get
Yeah.
agitation, restlessness,
Yeah.
akathisia type stuff.
Yep. Great question. So for the sensitive folks, I will, um, I always try medications first, like commercial medications, and then compound if needed. There are a handful of medications that are just inherently more immunogenic than others. Like cromolyn hurts for people that are very sensitive. Motegrity hurts people that are very sensitive. There's a certain groups of medication that I tend to stay away from when people are quite sensitive. Um, and then I use a GLP a lot in these patients at a really low dose because you can be like, you can start at whatever dose you want to. We can put you at the lowest dose possible. And it's generally speaking really well tolerated. Not always though. And then, you look towards compounding medications, but using medications that we think work well, right? Like and I apologize. I think injections are like well more tolerated than oral medications, just at conjecture. So I will use more GLP, Xolair in these folks, and then compounded medications. I tend to think that the immunomodulators, like the Plaquenils, that's obviously an oral medication, Xolairs and GLPs, LDNs work better than mast cell stabilizers, ones that actually change the way the immune system works. So I usually start there regardless. Um, but yeah, so injections I think are better because I think there's so many mast cells in the gut, and if they're really reactive, it's just tough to put anything in there. I just made that up, like that's just my musings. Also, I find that injections just are cleaner, so to speak. So yeah, so injections, and then if you're doing oral, compounded medications, and then if people can't tolerate that, then I work on the gut. So we talk about inulin, we talk about HMOs and things like that, and work on building up the gut lining because I've had folks who cannot literally tolerate anything. Everything makes them feel worse. And that's when I work on more gut lining therapies. Um, and yeah, so inulin, HMOs, um, and and it's you can play around glutamate. I don't find it to be super successful, but that's where I'll go. And then as you hopefully get them less reactive, and also like working on mental health as well, right? And so if people are really over, like you said, kind of the akathisia is really restlessness. Sometimes that can mean excess histamine, but sometimes people are just tipped towards sympathetic activation, like I mentioned. And sometimes like quieting that can be really helpful. And obviously there's like brain retraining and things like that, but like guanfacine is a really nice tool that I use a lot. Guanfacine is an alpha 2 agonist and it decreases the amount of norepinephrine. And sometimes, and not everybody, but people, they've been hurt by so many medications. Just the thought of taking another medication really revs up their sympathetic nervous system and will flare them in and of itself. And sometimes, getting them on guanfacine, you know, making sure they get good sleep, and sleep is tough to come by sometimes, but really working on that. And so if you can't stabilize the mast cells, like what other angle can we take? Is it decreasing the fight or flight? Is it working on the gut lining and just getting creative and seeing what kind of throughput you can take that is tolerated and always starting low and going slow.
Thank you. That's amazing. Thank you.
Yeah, that low and slow is so critical. And if you're thinking about supplements, that think of those from a systems perspective as well. And so, what is that supplement acting on in terms of receptors and things? And sometimes there's a lot of evidence and sometimes there's not. And sometimes the dose matters, like turmeric or curcumin, it really matters if you get to a higher dose or not, if you're going to turn on the TLR4, turn it off or quiet it down.
Yeah. And as John mentioned before, like a vagal nerve stimulator, right?
Yeah.
If nothing, you got to look towards things that your mast cells can't react to. I assume mast cells probably can react to a stimulator somehow, but it's probably that external hardware is probably pretty inert. So that's another option too.
Yeah, and there's another question about vagal nerve stimulation, and wondering if it harms or helps in IBS, mast cell, and so on. And we've talked about it a little bit, but in general, the concept of that turning the parasympathetic up, and so may then balance out the sympathetic, parasympathetic. I don't know if you have any sort of last comments on the vagus stimulation or not.
I think it's worth a shot. I think it's worth a shot. I don't think increasing parasympathetic tone like decreases inflammation of itself, but certainly decreasing sympathetic tone can. Um, but it's all really nuanced. Like we think of things as humans as very linear, like this does this, does this, does this, and it like doesn't do that, right? And so we're I just it's so complex. So and so it gets thrown into the bucket of why not, right? Like if you can afford it and you can manage it yourself, it's definitely something worth trying if you're considering it. And I'm like, I don't know enough about this space. I don't use them because I personally have not seen a ton of efficacy, but I'm not out on it. Maybe I'm just not using it properly. And so I mean I'm talking with a researcher on this in like an hour because I'm so
Mhm.
excited to learn more because I think it does have a role to play here.
And there was just anecdotally, we were talking or talking earlier this morning about something where somebody had tried it with a vagal nerve stimulus on the ear versus using one of the ones that does it on the neck and had phenomenal repeatable results on the neck versus the ear. And one certainly can um, think through that as there are different tracks and different parts that are going up and sort of the vagus nerve isn't a single unit. Tess, I don't know if you want to make a quick comment about that or not.
Yeah, I'm that patient who it worked for. So I'm using the True Vega one. And I
Yeah.
tried like three different methods of vagus nerve stimulation in the past, and nothing seemed to do anything for me until this one.
What do you mind if I ask how it's helped you?
How it's helped me? Migraines, so headaches and increased energy
Awesome.
are the main ones I've noticed. But just in general, overall, I sort of track an overall feeling of like, how good am I feeling this day? And that has gone up significantly. Just much fewer bad days, more good
Amazing.
days. Yeah.
Very cool. Very cool. And that's the
Um,
data is the
Danielle,
strongest for migraines.
Mhm.
But the energy is a cool piece too. Like
Yeah.
if you can fatigue with it. Yeah.
okay, Daniela.
Thank you. Thank you for taking all these questions for us. And I just want to thank you so much for all you do on social media. I am a mom just trying to learn everything I can to help my daughter. And so my main question is a lot of the time especially in the presentation today, the symptom is diarrhea, and I'm kind of wondering about more the motility constipation issue. Just very quickly to give some background, my daughter has POTS, diagnosed MCAS, superior mesenteric artery, partial obstruction, MECFS. And so her quality of life, though, is her GI problems, which we've just been given the general, dysfunctional dyspepsia, brain gut interaction, and, we're just not really getting anywhere. So I'm wondering, and I've used a lot of the information that you've provided on different places, which has been helpful. But are there any things here like GLP-1, for example, since her weight is so low, I would be worried. Anyway, just more in the context of constipation, or are there any things that are different, say, than if you're in more of a diarrhea situation and an overactive bowel?
Can I ask you a few questions?
Certainly,
Does she get really bloated?
yes, she hates that feeling,
Like really, really like
yeah, like a sip
messy?
of water,
Yeah. And is it right after eating or drinking?
pretty much, yeah.
Does she vacillate between constipation and diarrhea?
No, no,
No.
she never has diarrhea.
Always.
I mean,
How constipated are we talking about?
Um, well, the only way anything comes out is with 2 to 3 liters of water, a highest dose of linactotide that she can take, and
Mhm.
milk and magnesia every single day.
Okay. Yeah, it's really tough. Really, really tough. So, the bloating right after eating is very, very classic for MCAS. Like it's called in some circles in the functional world, like the Rome criteria is abdominophrenic dyssynergia, which they just recommend diaphragmatic breathing. It responds to a GLP medication. Just does. It's the hardest mast cell symptom to treat until I found the GLP. I
Okay.
hear you. I hear you on the weight thing. It's very scary. Um, and I can only tell you, and you've never met me, I'm just like a random guy on the internet, that I over 95% of the folks that I put on this medication don't have a pound to lose. Does it mean she won't lose weight? No. In my experience, it'd be very, very unlikely if she did at a microdose.
Okay, that's great to know.
The constipation is different. So many different inputs for constipation. I've seen people's like rectal evacuation get better on a GLP-1, which is so wild. Where like people feel like they can't they can't feel the rectum and they just don't have no urge, and it comes back with this, which is wild. But constipation has a lot of different inputs, and if she's not eating, enough fiber, right? Because she's not eating. I don't know that I'm not saying that's what she is going through. It's just there's fiber intake, water intake. Sounds she's doing a great job with water. If she's on a gluten-free diet, which a lot of people are, they're low in thiamine. Thiamine can be really nice for constipation.
I put her on that as a result of some of your other posts.
Okay.
Yeah.
Benfotiamine, 300 milligrams a day.
Yes.
And and then Linzess is not Linzess is great for the right person. People that are kind of in this space usually have more motility issues than anything else. And so I lean towards more motility agents like Motegrity, which tend to work okay. And you can actually go up to 4 milligrams. Um, and and then if it's really, really refractory, you got to look at tether cord, things like that. If she's hypermobile, and then if it's really, really, really bad, then I start thinking about visceraloptosis, where everything sags in the pelvis, like all the organs sag in the pelvis. So it's constipation is a really nuanced conversation, and at face value, it's thiamine is low hanging fruit, very well tolerated. A stimulant laxative may not be a bad idea, and treating the MCAS that'd be a good start. But I'd layer things in slowly, and not doing everything at once.
Yeah, I forgot the HEDS too. We're in the process. But yes, thank you so much. Again, thank you. And I've recommended you so many times to people, so I know there's more people that would thank you.
That
It's
means a
really
lot.
helpful.
Thank you very much.
Great. I think Michael has a question, or Sam has a question. Sam?
Yes.
Yeah.
Mostly just wanted to sort of tie things together and inquire. Might be one to think on and not necessarily be the easiest to answer so succinctly, but what do you think in terms of subtyping development? As far as heard you speak through a lot of different angles, a lot of different intersections of different, groupings of the heterogeneous syndrome. What's the most actionable to you in terms of subsets of patients or clusters?
You're talking about IBS clusters?
Whether it's IBS or ME/CFS or what label is sort of on the front, just sort of what layers do you tend to interact with beyond just, surface level, looking deeper at clustering and differentiating, are you one of these or one of those within just the heterogeneous syndrome as a whole?
Oh, okay. I think I know what you're asking. Just tell me to shut up. I'm going down a wrong pathway here. But when I see somebody with the triad of hypermobility, mast cell, dysautonomia, plus minus ME/CFS, plus minus autoimmunity. When someone comes in with GI symptoms, I generally put them in 3 different buckets. And it's oversimplifying things, but just helps my brain think about stuff. Is it compression? Is it inflammation, like mast cell, or is it dysautonomia? Compression, we think of SMAS, MALS, and pelvic compression, tethered cord, jugular venous outflow obstruction. That's less GI stuff. But and those symptoms have very classic triggers, like MALS after you eat, bingo, right away. Everything. SMAS, belly button pain, hour and a half after eating, usually bulkier things. There's some heterogeneity there, but it's usually that's the pattern it follows. Pelvic venous disease, lower abdominal cramping, sometimes to the back, heavy legs, right? And so you kind of get these, but it's pretty consistent. And then pelvic disease usually is worse when you stand up and sit up, and better when you lay down. Dysmotility, kind of there every day, no matter what, right? You get full all the time with the same foods usually are pretty triggering in dysmotility. Roughage, fatty stuff. The stomach's a blender, right? And in gastroparesis, the blades just a little bit overrun. And so things that are tough to digest, fat delays gastric emptying, roughage is just, it's tough to digest, makes people uncomfortable. Those people are usually on the brown diet. Rice, pasta, smoothies. Well, smoothies aren't brown, but you know what I mean? Softer foods. So they just kind of naturally gravitate towards that. They're every day, usually some flavor of constipation as well. Inflammatory, episodic, painful. Random triggers. Can tolerate sweet potatoes one day, not the next. Like systemic symptoms. Flares also with brain fog and fatigue and migraines and sinus issues. Um, so that's kind of how I think about things. And there's not a lot of data to push me in one way versus the other. Like obviously if someone has like compression, like we can look for that. But that's kind of how I think of things. And there's usually more than one thing going on. And it's committing to something. Be like, okay, I think this is mast cell. It could be dysautonomia or it could be compression, but I think it's mast cell for this. Let's lean into this and see where it goes. And if it's not working, then maybe we'll start to talk about these two things down here. Or sometimes we're like, forget it. You want to do the whole shebang? Let's do it. Let's treat mast cell, but also let's get some imaging for malls or whatever. That's kind of how I think about this. But I see. And did I answer your question, man? I'm sorry. I don't know if that was
Yes, thank you.
okay.
Great. Thanks, Sam. So we're going to try to just get a couple more, maybe three more questions, and then Isabel will wrap us up. So we've got about 2 or 3 minutes, or about 2 minutes to go with these next few questions. Any tests specific to specific staining on biopsy that can reveal exactly what is going on with the gut barrier to inform the approach with gut barrier support or drugs? So I guess it's biopsy versus not biopsy, and then is it a specific test that needs to be done or just standard biopsy tests?
Yeah, I don't think histopathology is important here. If you have, in my opinion, if you have signs and symptoms of mast cell activation syndrome, there's inherently barrier disruption. Like that's part and parcel. It's not, and it won't change necessarily what you do. As an aside, there's some thought about doing biopsy and staining for mast cells. I don't recommend it. I think Dr. Efron really disagrees with me here, and that's okay. We can all have our opinions. I think of mast cell as more of like a behavior thing. They're overactive as opposed to too many numbers. And plus we don't have like a lower and higher threshold of what it is. And so it ends up being more noise than anything else. And it's like, oh, my numbers were 17. Does that mean I don't have? It's like, I don't know. We don't really, this isn't standardized, right? And so also, where do you biopsy? Like, is it in the stomach? Is it the small bowel, right? Is it the colon? We know that terminal ileum has lots of mast cells in everybody. So it's like, I don't know. So I use EGD, colonoscopy biopsies to rule out mimickers. Crohn's disease, UC, polyp screening if you're of age that need colon cancer screening, HP, H. pylori, eosinophilic. We see a lot of eosinophilic disorders. So yeah, but unfortunately,
the concept here of using really listening closely on history and the path and the symptom and the trajectory and ruling out initially red flag syndromes of things that are more urgent, then you can start using treatment or the initial treatments as part of the diagnosis. If you think it's mast cell and you give H1, H2 blockers and you get a good response, it's at least partly mast cell, and you can keep going from there. And that seems to be a kind of a generally universal in this space. I think this will be our last question. Are there any tests or did that one already? And then just a connection with all this with POTS.
yeah. So some people have like dysautonomia or POTS symptoms that come and go. Mast cell can cause that 100%. It can cause venodilatation, pooling, tachycardia, dizziness. Like it feels just like POTS, but then like they're like, well, I did my POTS test on a good day. I was like, well, it's not, you don't have POTS. You have mast cell induced dysautonomia that can come and go. I think that the POTS, and there's, some patients do have POTS where it's every day, all day that they get orthostatic intolerance. They stand up, they get uncomfortable, dizzy, lightheaded, tachycardic. And I think that's via small fiber neuropathy would be my guess. That's my read on it. It's that inflammatory process driven by mast cells, the complement system really burns off those small fibers, and you get loss of the A delta C fibers, and that messes with the communication between the autonomic nervous system and the blood vessels, and so you get more blood pooling. That's my read on it. So some people, I think EDS, HEDS, not EDS in general, HEDS and MCAS I think is one thing. I think the overlap is 100%, right? So I think we're getting to the point where like there's Ehlers-Danlos and there's hypermobile EDS, which is like a neuroimmune condition, right? I've never met someone without the other. And there's some people who have MCAS who are like, I'm not bendy, but I was like, well, do you have like neck tenderness and do you have like pelvic floor dysfunction? Like there's flavors of hypermobile EDS in these patients. And some people end up getting the small fiber neuropathy induced POTS. And that's that's my read on things. And then you treat that separately.
Wonderful.
Well, thank you so much. And let me hand it over to Isabel to close us out. And there's still questions, but there are about 75 people still on the call. We had over 100 or so. And
Yeah, a lot of questions. Thank you for everybody that, hung with us for this amazing 2 hours. Thank you so much, Dr. Spiritos, for your generous gift to us of your time and expertise. We will be posting this recording to our YouTube channel, and we'll make sure to share with you for your audience, Dr. Spiritos, as well. And thank you, everybody. Check out our YouTube channel, check out our social media, and the same for Dr. Spiritos for all the information that comes out that can help us and can help our clinicians continue to treat us and improve our quality of life. Thank you, everyone. Bye-bye.